and these presenters will be judged by Professor Ziaul Islam and Professor Qayyum. The judgment points are presentation skills, novelty, time, respect, and sir, और क्या है?
Skills,
presentation skills, and Q&A. The best presenter will get the reviewer best presenter of Editor's Choice Award at the end. You have got 7 minutes, and our first presenter is Sumayya Ali Khan. Sumayya, are you here? And her topic is the Dermis Fact Graph Retrospective Case Series from Pakistan.
First of all, I would like to extend my gratitude. It's indeed a huge honor to have you published and acknowledged at such an esteemed platform. So the topic of my presentation was the Dermis Fact Graph. It was basically an institutional assessment of our performance of this particular surgical technique. Here is the reference to the publication. So our motivation was to improve the outcomes for our patients with diverse and difficult socket conditions, which we routinely see in our OPDs, and to document real-world outcomes, and finally refine our practices. And it's also important to share insights with surgeons who are exposed to similar cases. So the advantages of Dermis Fact Graph, just a brief description, that it is autogenous tissue, it's taken from the person's own body, and obviously then there is no rejection or reaction problem. The volume and the surface both are augmented, and in pediatric cases, the additional advantage is that it gives the impetus of bones to the facial bone structure. So it was a retrospective case series of 25 patients, so 25 eyes of 25 patients enrolled from January 23 to July 2024 at Ashwa Trust Eye Hospital, Rawalpindi. And our criteria for the study sample was, we included patients who had anophthalmia due to any reason, good general health, so that we could do a procedure under general anesthesia, and the ones who maintained their follow-ups. And how did we select the patient? The lack of volume in the socket was defined as a deep superior sulcus, even with the external prosthesis in place. The exclusion criteria was obviously the first and foremost patients who could not undergo general anesthesia, predisposition to keloid or hypertrophy of scar, or a discharge of the socket. And severe lid trauma, in which it is better to go ahead with an exentration rather than socket reconstruction. Right, so in our cohort, we had a total of 25 patients, 15 males and 10 females. The age distribution was a very broad range. We enrolled patients from 3 to 53 years. The average was 34. All had secondary anophthalmia. Majority of them, 23 out of 25, had trauma as the cause of loss of jaw, and 2 had malignancy. So we selected cases, we do a standardized surgical technique. We take the Dermis Fact Graph from the upper outer quadrant of the gluteal area, and we implant it in the orbit, plus minus fornix formation depending on the degree of volume loss. And then we discharge the patients with oral antibiotics for 5 days, topical antibiotic and steroid combination drops, and an ointment at night. So this is a standard protocol. General wound care was advised, and the leg sutures of the donor site, they were removed at 10 days. All patients were seen 2 weeks post-op, and all patients had their photographs taken at each visit. So subsequent to this, we got them for an ocularis review and fitting at 6 weeks, and after that we saw them at 6 weeks, 3 months, 6 months. The photographs were taken at each visit, and unfortunately this is the maximum follow-up that we can have. Because once the patient has gone to the ocularis, we usually don't come back to the ophthalmologist. The complications that we encountered during our period of study was fat resorption, which is a documented side effect of Dermis Fact Graph. So it's always unpredictable. So 2 out of 25 of these patients had to be relisted because the graft underwent atrophy. 3 of our patients had infections. It was controlled by simple course of topical antibiotics. No patient reported any complication at the donor site. Now, I do have a few cases to show, and if time permits, I do have a video of the procedure that we did. So this was our first case of a lady, and we can see that there's it's a very shrunken socket. So, do I have the time to play the video?
Yes, you have. 3 minutes.
So this is a procedure. We do the socket inspection and open the conjunctiva and measure the depth of the fornices and the area that we have. Then we do the skin marking at the gluteal area and raise the graft in an elliptical form. So this is local anesthesia at the level of the epidermis and the dermis, so that we get a purely orange appearance. We give the incision, and then we carefully peel off the epidermis from the dermis. So the dermis should remain on the graft, because that is going to replace the conjunctiva. And once we've done this, meticulously making sure that it is the dermis that we see, we remove the graft. So we go in deeper and take a good chunk of the fat along with it. We can speed it up a bit. So we've taken, I don't know if the quality of the video is good there, but I can see the colors there better. We do the skin closure of the donor side with proline, non-absorbable sutures, and remove it. This is the graft on the gauze. And then we put it in the area. The dermis is sutured to the conjunctiva and impact the socket. This is the socket fully filled with the fat now. And this is it. So this lady, okay, so this is the second case of a gentleman with a very shrunken socket on the left hand side. And this is him post-operatively. So this is not the standard prosthesis, it's just the conformer in place now, the colorless conformer. We put in the prosthesis afterwards. Unfortunately, we didn't have a picture of that, but he has very good volume and he's still coming to us. This is another gentleman. We did his surgery, and this is the conformer in place, followed by the prosthesis, and this is a very good prosthesis. Very happy with his outcomes. And removing the conformer, you can see that the fat, the graft has been taken really nicely. So we take a patient satisfaction, we don't do a formal questionnaire, but we do speak verbally, and they were all very happy. None of the patients reported any unhappiness. So I would just briefly conclude now, I'm running short of time, sorry to go over. We do have limitations. We need a longer follow-up to certain the outcome, and we need a larger cohort. This is a single institute study, so we need a broader range, and loss to follow-up is a huge problem in our part. My acknowledgements are my supervisors and the surgical team, the patients and families, and the research department of our hospital, without which it wasn't possible. Our references, and so it is a valuable, reliable, versatile option in challenging sockets. Thank you very much. I would just like to end that quality is never an accident. It's always the result of intelligent effort, and we must persevere.
Thank you. On to our second presenter, Dr. Zubair, and his presentation is on the clinical impact of transphotoreflective keratectomy and femtoral second laser in situ keratomyosis in patients with myopia and astigmatism. Dr. Zubair, please. You have 7 minutes, and try to respect the time, please.
Thank you so much. I'm Dr. Muhammad, PhD scholar at PJO University and head of the department at PJO University in Dhaka. Today, the topic of my presentation is assessment of clinical impact of trans-PRK and femtosecond LASIK in patients having myopia and astigmatism. This study was done under the supervision of Colonel Aman Satim, Honorary Hospital, Dhaka. The objective of this study was to assess the variability, contrast sensitivity, and higher order volume of the two effective surgery procedures, trans-PRK and femtosecond LASIK, and to compare the clinical impact of trans-PRK and femtosecond LASIK. The material and method the study was experimental longitudinal study. This was done at Hospital, PhD, and study sampling technique was non-probabilities, a convenient sampling technique, and the data was analyzed by the repeated measure ANOVA and independent t-test. The inclusion and exclusion criteria patient was between 18 to 36 year age, both gender, simple and compound myopic astigmatism, moderate myopic patients, myopic and astigmatism undergoing trans-PRK and femtosecond LASIK, and having standard central corneal thickness of 500 micrometers. Exclusion criteria was less than 18 and more than 36 year old. Any ocular pathology, any inflammation or any other thing, and CCT less than 500 micrometers. Data was analyzed by SSPS 25 version and repeated by ANOVA, and there was 2 and 3 follow-ups, and the independent t-test was done to assess the difference between these two procedures. This was the data collection method. Informed consent was taken, detailed history, ocular examination, visual acuity, contrast sensitivity, and topography, examiner laser, and follow-up after 1 week, 7 weeks, and after 1 month, 2 months, and this is the studies also now continued further. This is important. Result shows that trans-PRK give better result from femtosecond LASIK in sense of contrast sensitivity and higher order brilliance. And my recommendation is strategies to be done for the further according to the patients and their visual status and their outcomes and their center corneal thickness for the better results in these respective surgery procedures. Thank you.
Any questions?
Also, make sure that there is an active involvement of the retina of the This is a little update from our.
Any question?
Thanks.
So our next presenter is Mubashara Tariq. Is she here? No? Then is Imran Ahmed, Dr. Imran Ahmed. His presentation is on visual outcome and complications in retropupillary iris claw intraocular lens in patients with insufficient capsular zonular support.
Thank you very much, madam. Actually, I made presentation keeping in mind that it's a 10 minutes presentation. Anyways, I have to be a bit quick. So it's about the visual outcome and complication and retropupillary iris claw intraocular lens in patients with insufficient capsular support. This is the article that is published in PJO early in this year. Cataract surgery is the most common surgical procedure performed in ophthalmology everywhere worldwide, and it is not risk-free. It is associated with many complications, and the most common complication encountered specifically by the juniors is the rupture of the posterior capsule. And if we can, cataract surgery is never intended, but sometimes it happens. And then when there is limited posterior capsular support, actually we have very limited options, and the option in deficient capsular support and associated complication, that is that we can go for the scleral fixation IOL or for the anterior chamber intraocular lens. Among these options, one is the iris claw IOL in cases of deficient capsular support. And iris claw IOL, actually it can be placed in front of the pupil and are retropupillary position. This is artisan iris claw IOL, artisan design. The aim of the study was to determine the visual outcome and complication associated with implantation of retropupillary iris claw intraocular lens in a tertiary care hospital. This was conducted in the Khyber Regional Hospital, and the sample was collected by non-probability consecutive sampling. If a patient with insufficient capsular support, subluxated or dislocated intraocular lens, and as a primary procedure, and patients with weak zonules were included. Atrophic iris, dilated pupil, corneal scar, or posterior segment pathologies were excluded because we cannot place iris clival and atrophic iris or if the pupil is very much dilated because it has limited diameter. IRB approval was taken, the number is given. This is the, I have mentioned the procedure and the methodology as well, that we have to give to incision 3 at 9 o'clock for the clot to be inserted. And usually these are the complicated procedures. You can see the sutures are over there. It is aphakic patient. The anterior vitrectomy is done, and after anterior vitrectomy, we have to make the iris round if it is irregular. The sutures are removed, and then at 3 and 9 o'clock, because the iris I have shown that it is having the clinch at the hooks that should be placed embedded within the iris. When you just press the iris, it will be embedded over there, and that's the end of the procedure. It came with this. I have placed it in the vitrectomized eyes as well. This was a patient of it was a patient at which the nucleus drop happens, and as a primary procedure, we didn't go for the iris clival, but later on, the AC maintainer is there because there is fluid inside the eye. And still you can see the iris lies beautifully placed within the center. So post-operative assessment is basically the visual acuity, the inflammation we need to check, the intraocular pressure, iris irregularities. This is the most common complication associated with iris claw because the claw has to be anchored within the iris. The centration of the lens most of the time, because once it's clipped, it's very difficult to remove again it from the iris tissues. The centration of the lens, corneal transparency, because most of the procedures like anterior chamber intraocular lens that is associated with the corneal damages or inflammation and posterior segment pathologies. This is the demographic data. Then the indications, and our study actually posterior capsular rupture was the most common complication, that's in 52% of the patient. Subluxated IOLs, IOL drop, traumatic cataract with phacogenesis, nucleus drop were 7, so total number of patients were 35. These are the complications, no complication, and 74% of the patients post-operatively with placement of the iris clival were without any complication. Irregular iris is the most common complication. The second one, high IOP, IOL subluxation in one patient, cystoid macular edema, and hyphema. This is the comparison of the pre-operative and post-operative visual acuity because definitely the capsule was ruptured, the patients were aphakic, so the pre-operative visual acuity were less. And 77% of the patients were having visual acuity better than 6/18. And 85% of the patients visual acuity better than 6/24 after implantation of the iris claw IOL. The comparison of the pre-operative and post-operative that was clinically significant, having a p-value of less than 0.04. Iris claw is an effective procedure with minimum complication and comparison with the other procedure that is done as in the deficient capsular support cases. ACIOL is associated with glaucoma, corneal endothelial decompensation, porous keratopathy, uveitis in comparison with the iris claw IOL due to mainly its retropupillary position because it is placed in the posterior chamber behind the iris. So it's not associated with all the complication with corneal complication. Iris irregularities were associated in 14.3% of the cases out of the 22% of the total complication that encountered via our studies. Other studies have shown the iris irregularity in 10 to 30% of the cases, means that I already mentioned that the most common complication is iris irregularities. Only 11% of the patient in our study had visual acuity of 636 or less in comparison to the 660 or worse preoperative visual acuity. 94% of the patient vision improved in comparison with the preoperative vision, and Kelkar et al. Showed that after iris claw IOL, the vision improved in 85% of the patients better than 6/18. And a study by YH showed that the iris claw IOL are associated with lesser chances of IOP elevation, cystoid macular edema, and corneal complication, keeping in mind its position to be placed behind the iris in comparison with the other options. The limitation is it was a small sample size, limited follow-up because we followed the patient after 2 weeks after removal of the sutures. Single center study it was, and no comparison was made whether the anterior chamber IOL, clear fixation IOL, or other types of intraocular lenses that can be placed in aphakic patients. So large study should be done. There should be multi-center trial and comparison with other alternative procedures in the same cases. So IRIS-IVL is a safe and effective procedure which is less time consuming and associated with favorable visual outcome and patient with the deficient support for placing posterior chamber and the back or sulcus fixation intraocular lenses. These are the references and the declaration that is already published over there. Thank you very much.
So I have two questions. First, how do you make sure that the iris claws of the lens have adhered or have?
Actually, basically, there is specialized for that, and you might have seen it in the video as well. When you click it, the hinge is clicked within the iris, you have to move it, and that is visible. That whether it's free or not. Because if you leave the iris claw as such, you are in the posterior segment. Because you have to go behind the iris, then it will drop. On one side, you have to move it. Exactly. That sometimes it's not visible because you have to make again. It depends that which instrument you have used. Usually, I'm using the that is the visco cannula. But you can use other instruments as well. For just you have to press it over that hinge area and it will be clipped with an iris. Then you have to move it. Slightly move it, then it's quite obvious that it's over there, and then you have to put the other end as well behind the iris and then click it again and again. You have to look for that. And once it's anchored, so far because it was published early and it was done in 2024, and now I have done I think more than 100 cases of iris well.
What is the cost of this lens?
Madam, first it was on 800, now I think it's on 2500.
2500?
2500 it is. Actually, basically, it's not was not available. Then I asked a person, and then we ordered it, and then we started it over here.
So it's a very good option. Thank you very much, Dr.
Very good option, madam, and very easy option.
Our next presenter is Wasim Sajjad. Dr. Wasim, are you here? No. So, Dr. Zahirullah Babar. This is our last presenter, and he is going to talk about effectiveness of temporary keratoprosthesis in vitreoretinal surgeries. Start, please.
I'm Dr. Zahir Babar, currently working as a senior registrar in the Vitreoretina department of PJO Medical College. And our article was on the topic of effectiveness of temporary keratoprosthesis in vitreoretinal surgeries. This procedure was introduced by Professor Biradisha some 5 years ago, and so far we have done around 20 cases in the last 5 years. 15 of those cases are included in this study. And I believe that this is probably our institute is the only institute which provides this surgical approach in Pakistan. Before starting my presentation, I would like to show you a small video so that we have an idea what we are about to talk about.
अपना नंबर भी लिखना है।
So temporary keratoconus is actually used in cases where there is a posterior segment pathology, retinal detachment, an intraocular foreign body, metallic intraocular foreign body, and in those cases you need pars-plana vitrectomy as well. But due to insufficient corneal clarity, the posterior segment surgery is hindered. So we perform a combined penetrating keratoplasty and pars-plana vitrectomy in those cases. This study was done to evaluate the effectiveness and outcome of this combined procedure. It was a retrospective case series of 15 patients from 2020 to 2024. The inclusion criteria was patients who had insufficient corneal clarity with posterior segment pathology. The outcome measures cases or successful cases were defined by if the patients maintained their visual acuity or it improved with an attached retina, a clear cornea, and a normal intraocular pressure. The surgical steps first that of the placement of the sclerotomies, then after that the trephination of the resection bed, then placement of the temporary keratoprosthesis. This is here the placement of the temporary keratoprosthesis occurs, and then you can do the fundus from there, and pars-plana vitrectomy is being performed, and after the pars-plana vitrectomy, placement of a tamponade, there is a clear graft which is then sutured. So corneal laceration with retinal detachment was the most frequent reason for this surgery, occurring in around 8 of our cases. Other indications were cases of intraocular metallic intraocular foreign body, metallic intraocular foreign body whether with a retinal detachment, and there was one case of bullous keratopathy with a nucleus drop. The surgical steps first, that of the placement of the sclerotomies, then after that the trephination of the resection bed, then placement of the temporary keratoprosthesis. This is here the placement of the temporary keratoprosthesis. This is here the temporary used in majority of the cases was silicone oil, 1000 centistrokes in 5000 centistroke in one case, and air was used as a temporary in one case which had no oil, by the way, the case to the nucleus drop. Visual acuity improved in 5 patients or 33%. It remained the same or stable in 53 or 8 patients. It was in 2 of the cases. Functional vision was achieved in 40% of the cases. We defined functional vision in our study as hand movement or better. Complete surgical success was in 2 cases. Complications were mostly in 10 cases we got a graft failure in 73%, recurrent RD in 8 cases, raised IOP in just 3 cases, and lysis in 2 cases. These are some of the models of therapeutic keratoprosthesis. Towards the left, this one is the original PMMA keratoprosthesis. The other one is the wide field blenders. We are using this one. Wide field blenders, and the third one is silicone keratoplasticity, but it had different complications, and the durability of this one was less, so it is no more available, not manufactured anymore. So the summary is that therapeutic temporary keratoplasticity is evaluated for patients having a corneal opacity.
Sorry to interrupt you, Dr. Saab. As these sessions are meant to promote research as well as to train our presenters regarding how to present. So when the bell is rung, it is better that you should try to end.
Yes.
You can spend only a second or 2 in every slide. पिछली slide पर जाएं. इसे पिछली वाली पर. You can skip this slide by saying that the maximum complication, the majority of the complication, the major complication was graft failure in 73%, and you can move forward. तो अब जब दोबारा सारा पढ़ना शुरू कर देते हैं, एक तो सेशन का टाइम जो है वो डिस्टर्ब हो जाता है. So it's for your advice, for mashallah, you are going to present a lot of more presentations in the upcoming conferences. तो उसके लिए ये है कि अव्वल तो ये है कि the first thing is that you should practice the time before you come over here, and the second is that if the time is short, then you can skip the rest of the things, only pointing out the a key point, and then you can skip these slides. आपने पूरा ये पढ़ा है, जी sir.
I think you spend most of your time by presenting the operation. You see, most of your time was consumed, you see, initially by doing your operation show, and you see while you are stitching and so on. You see the other slide that you showed, where you said this is the keratoplasty, this is that was enough. You see, initially you spent a lot of time for the operation, so that's why you couldn't get time to do the other discussion.
Sir, actually, the whole idea of having a keratoplasticity and doing a combined surgery, it is a novel technique. Most of the people don't even
जी सर देखेंगे प्लीज. One more. Okay sir. Thank you.
Congratulations, sir. अच्छा.
उन्होंने बहुत हाई डिपेंडेंसी यूनिट का नाम दिया है और वो वहाँ का डाटा ही नहीं प्रोवाइड करते. वो कहते हैं कि ये बच्चे तो सरवाइव नहीं करते, तो आप इनका डाटा ना लें. ये मैंने जब सारा आरओपी कोऑर्डिनेटर से पता किया तो मुझे पता चला कि वो बच्चा वहाँ एडमिट रहा 12 डेज, वो सरवाइव कर गया और वो बच्चा सरवाइव हुआ, डिस्चार्ज हुआ और अब वो स्टेज 5 आ रहा है.
अब तो वो कमरा सबसे इम्पोर्टेंट.
So, sir, मैं announce करूँ. So the results have come. Dr. Imran Ahmed, he has got the first prize. जी, माता
Yes, sir. Yes, sir. Samna, please. Thank you. एक मिनट.
Thank you.
Congratulations. बहुत मुबारक.
मैम देखेंगे प्लीज. Good. Thank you.
बहुत मुबारक. डॉक्टर जुबैर नजर.
Ma'am, please. Excuse me, ma'am. Okay, sir.
डॉक्टर जहीरुल्लाह बाबर. काम तो बड़ा अच्छा कर रहे हो आप.
जी मैम, प्लीज.
बातें सीख ली हो.
Excuse me, ma'am. Thank you. Ma'am, please. Thank you.
और नेक्स्ट ईयर से मैं सोच रही हूँ कि बेस्ट वर्कर ऑफ द PJO का अवार्ड भी शुरू कर दिया जाए. सर क्या ख्याल है?
होना चाहिए.
होना चाहिए. अगर होता तो मैं सब जाता.
इसके साथ साथ बेस्ट एडिटर को भी शामिल करें.
किसको?
बेस्ट एडिटर.
डॉक्टर दानिश नहीं सर, ये दानिश रियाज. इसकी एक खासियत है कि ये इमरजेंसी में काम करता है. सारा पूरा महीना इसको कहते रहेंगे हो जाएगा मैडम, हो जाएगा, हो जाएगा, नहीं करेगा. लेकिन जब करने पर आता है रात 2 बजे काम करके दिखाता है.
Excuse me, ma'am. Good. Good. Thank you.
हाँ क्या खत्म हो गया टाइम? मिस्टर हुसैन बाकी लोग नहीं. अच्छा, हमारे पास और भी हैं. वी हैव our publisher Kovac is working efficiently with us. Mr. Hussain, Rabil, Alam, they are not here, and we have 2 more certificates for our worthy judges. और माशाल्लाह सर और सर they are, क्या बात है इन लोगों की. They have always supported Pakistan Journal of Ophthalmology. और जो भी सेशंस होते हैं, कोई आए या ना आए, they are always here to support us. जजेस के नहीं तो ये ना इसके बाद में बाकी है. वो रात हो प्रोफेसर ज़ियाउल इस्लाम.
जी मैम, प्लीज. Yes, sir. Thank you.
Thank you very much, sir. प्रोफेसर अब्दुल कयूम.
Yeah. Thank you.
Thank you very much, sir. सर इसका नाम.
Go ahead.
So we are.
एक मिनट वेट करें. चलिए आप मुझे सर वो बगैर नाम वाला दीजिएगा प्लीज. आप साथ आइए. ऐसे ही जबरदस्ती खुद कहाँ जा रही हो? हमारे साथ तुम्हें 10वीं की थी.
नहीं तो सर्टिफिकेट तो है.
आ जाना यार. सर आप सर्टिफिकेट के बगैर खिंचवा दो. आओ यार, शीट तो खिंचवा दो.
वो सर्टिफिकेट बात
नहीं बगैर
सर ये प्लीज.
नो सर.
हाउ कैन आई?
Yeah.
Thank you. Thank you. Thank you.
Sir, ये third year.
Third year. I think this is very. I think you have to inform all the branches. Have you informed all the branches?
नहीं sir.
You see, because you have to inform all the branches that there is a competition of best paper, so that other people can also participate. So
Next time से definitely. So वो प्रोग्राम होता है पूरा, तो it's for everyone. उनको पता तो होता है, लेकिन डेफिनेटली नेक्स्ट ईयर से इंशाल्लाह ब्रांचेस को इन्फॉर्म करेंगे.
उसमें बात यह है कि भाई ब्रांचेस को पता चल रहा है, तो वहाँ पे वो अपने एग्जीक्यूटिव कमेटी में या मीटिंग होती है उसमें वो डिस्कस कर लेते हैं. वैसे तो लोग नहीं लेते, लेकिन this is my suggestion anyway.
Noted, sir.
And I think it was a very good session. All the speakers, they were very good. And this is also a sort of learning, you see, because when you are doing presentation, and as Professor Saiba, she sorted out, when you have to prepare your presentation in such a way that your main aim should be over there. And if you are short of time, you can just go through without doing prescription, just giving a headache, and that will be enough. Thank you very much for watching. You can conclude your session. Thank you.
जी सर, सर की वर्ड्स।
मोइन साहब ने कहा कि जी अब हमने हाथ उठा लिए, मैंने काफ़ी कर लिया है, अब आप जो है नई सिलेक्शन पीजीओ की लाइन, तो काफ़ी मुखालफत भी हुई सिलेक्शन करते वक्त, लेकिन माशाल्लाह प्रोफेसर तैयबा ने प्रूव किया कि काफ़ी शी इज़ हार्ड वर्कर और पीजीओ को माशाल्लाह बहुत ऊपर लेके जा रही हैं, और हम चाहते हैं, हमारी दुआ है कि और पीजीओ तरक्की करे। थैंक यू वेरी मच।